panel, Nothing for Us Without Us, Prioritizing Adolescent Sexual and Reproductive Health in Emergencies. I am Khadija Moore, a native and youth advocate from the island of the Commonwealth of Dominica. I'm an advocate with the International Planned Parenthood Federation and also Women Deliver Young Leader of 2018. I have worked on various I have worked on various projects for advocacy and volunteerism within the family planning movement and the sexual and reproductive health and rights arena. I have coordinated campaigns and launched NGOs to help support women who were victims or basically survivors of gender-based violence. Let me begin by expressing how happy I am to see all of you here, and we're very glad to have you here today. A fun fact is, with the over 200 people who are joining us today, over 30% are young people who are below the age of 30. So we're very excited that you can join us, and we're very excited and ecstatic to have a diverse group with us today. It is really good to see you all, and we know that it is a stressful time. The world is facing a pandemic, and we understand that things have been a lot worse for young people, and not just young people, everyone. However, we know that adolescents will always feel the brunt of it because they have unique needs, especially in the advent of COVID-19. So, as you may know, this discussion was due to take place in February at the annual meeting of the Interagency Working Group on Reproductive Health in Crises. But because of the coronavirus, we had to, and the health issues that it implicated, we had to force a postponement. We felt it was very necessary to have this panel discussion today, and especially now when adolescents face even greater health risks and challenges, health and overall health. We have 3 speakers from the International Rescue Committee, the United Nations Population Fund, and I'm sorry, it says that my internet connection is unstable, so bear with me if it lags a bit. And these 3 speakers I will allow to introduce themselves in an effort to make this session more interactive as we go today. Thank you. If we could allow the speakers to introduce themselves, and then we will continue with the objectives.
Hello. Good afternoon. My name is Dr. Hala Al-Khayer from Syria. I am a pediatrician, and also I have master in public health. I'm working with UNFPA Syria country office as a head of reproductive health program. And it's my pleasure to be here with you. I have long experience working and volunteering with NGOs to support younger and women. And I used to be a member in one of the NGOs in the youth committee and later in women committee because of the age, of course. So I'll be very pleasure to provide our experience in Syria, and hopefully you will enjoy with us. Thank you.
Thank you.
Hello. Hello, everyone. My name is Edan Getachew. I work for IRC as a health coordinator. the country I'm working in is Ethiopia. I'm from Ethiopia. I have experience of working with different NGOs, especially concerning adolescent reproductive health, maternal and child health. And I'm very pleased here to share with you the IRC experience on adolescent reproductive health. Thank you.
Hello. This is Argo from Ethiopia. I'm just with Eden. Thank you for hosting this session, and so I'm just pleased to be part of the discussion. And so I'm going to share the RSC Ethiopia's experience on ASRH, and I'm working as MND manager for the health unit at RSC Ethiopia. Thank you very much.
Hello, everyone. I'm Sarah Ashraf. I'm the Director for Maternal, Newborn and Reproductive Health and Emergencies with Save the Children. I have worked in the field of reproductive health for many, many years, as well as emergency health in different humanitarian settings. Today, I bring our example from our Yemen program, where we do ASRH programming, and we had the chance to speak to some of our adolescents as well as our health facility service providers. So I'll be sharing that with you all. I have been supporting Yemen quite for some time, so I'm aware of the context and the issues there. Thanks.
Thank you. So as you all know, the Interagency Working Group is a broad-based and highly collaborative coalition of more than 20 steering committees, member agencies. Some of these represent the UN, government, non-government organizations, research, and donor organizations. It was founded in 1995, and currently a network of over 2,100 individuals exists from 450 agencies. So we all know that IWAG remains committed to advancing sexual and reproductive health and rights, especially with people affected by conflict and natural disaster. We now move into the objectives, which are to explain why adolescent health needs should be prioritized, especially during crises and emergency settings, to discuss best practices, results, and lessons learned when meeting the unique needs that adolescent boys and girls face. Also, we are here to reflect on accomplishments and strides taken to address ASRH needs and to speak on areas where we need to put a little bit of extra effort and focus. So, we will move to view an adolescent sexual and reproductive health in emergency settings video, which was developed by IWAG's Adolescent Sexual and Reproductive Health Sub-Working Group, along with two young leaders who are Bisharo Ali Hussein. This video aims to educate us on adolescent health needs, on why adolescent health should be prioritized in emergency settings. And after the video, following the video, we will take 1 minute to reflect on everything that was said, and then we will move on to the presentations.
Meet Dalia
and Usman.
After an earthquake struck, Dalia and her siblings have not been able to find their parents. Dalia has to take care of her family, but food is limited, and getting wood to keep warm is scary.
Usman's mother screamed at him to run as their village was being burned by an armed group. When he returned, he discovered his parents had been killed and his siblings were gone. An older boy approached him and told him they would protect him.
Dalia and Usman represent the millions of adolescents and young people living in emergency settings across the world.
Why should we care? There's 1.2 billion reasons to care. During emergencies, adolescents face disrupted or destroyed family and social structures, separation from support networks,
and a new environment full of dangerous and unfamiliar conditions, making it more difficult for adolescents to protect themselves.
When a disaster strikes, adolescents' sexual and reproductive health needs do not disappear. They increase dramatically.
Dalia continually faces the risk of sexual abuse, exploitation, and violence. She may feel forced to approach the men in her village to get more food and water for her family, at whatever cost that may be.
Usman feels alone and scared. This older boy offers protection, even if that means becoming a child soldier. Doing so may require him to do things he is not comfortable with, and the armed group may ask him to show his loyalty by killing another person or using rape as a weapon of war.
In humanitarian settings, adolescent girls and boys face increased risk of sexual abuse, exploitation, and violence, including rape, transmission of sexually transmitted infections. Adolescent girls have unique risks. Adolescent pregnancy and childbirth are extremely dangerous because their bodies are not ready to have children. These unwanted pregnancies also increase the chances of unsafe abortions and maternal mortality. These risks are exacerbated during emergencies as barriers to accessing services increase.
Adolescent boys also face unique risks. Not all adolescents are the same. Aside from gender, there's age, sexual orientation, disability, marginalization, and other factors. Their needs, barriers, and risks also differ and often go unmet, due to their age and assumptions about what they need or want, and their abilities to make their own decisions.
However, adolescents are creative, passionate, and resilient. They are capable of developing creative solutions to difficult situations and have the assets to do so.
From the onset, we must meaningfully engage adolescents both during the emergency and through to recovery. Building support from their community, particularly its leaders, is critical to increasing access to and use of sexual and reproductive health information and services.
We must strengthen links between services that adolescents need and use. All these strategies require looking beyond health facility services.
We must think about how the approaches work together
to adopt a holistic lens and collaborate alongside adolescents and young people
to save and improve lives.
We will allow for 1 minute to just sit back and reflect on this video that we just viewed. Thank you. So we see just by this video, we know that both young men, women, and adolescent boys and girls face very different needs. They face very different challenges and have different needs, especially when it comes to their sexual and reproductive health. Their sexual abuse, forced marriage, a lack of access, and lack of access goes for both boys and girls. unwanted pregnancies and early pregnancies may lead to unsafe abortions, and in some cases, or in a lot of cases, maternal mortality. Right now, I will basically share a little bit of my experience. It was with a natural disaster, or two of them. In 2015, my country was devastated by one storm, Tropical Storm Erica, and we saw it was very difficult for people to access not only food and water, but for young people to access reproductive health services. Also in 2017, we were decimated by Hurricane Maria, and on the ground, like, you learn about these things online or you see it on TV, but on the ground it's a different story. We know that there's increased risk of gender-based violence, and in some cases, the Bureau of Gender Affairs reported that soldiers who came to assist in the recovery and relief efforts, they basically exploited young women, and they abused their power and the position that they had, basically to help persons. So we understand that there are different needs that young people face, and there are specific needs that adolescent boys and girls face. And just knowing that in emergency settings, it is 10 times worse, and especially now with the advent of the coronavirus, we understand that young people and adolescents are facing increased risks and greater risks, and we're going to learn a lot more about it with our speakers from the UNFPA, the IRC, and Save the Children. So now we move into the presentation aspect of it. And we will start with Hala. Thank you very much, Hala.
Thank you very much. And it will be my pleasure also to receive any comments, any information you can. It will be an added value for us in the future to expand what we already worked in Syria. I will start with the presentation. I'm not sure if it's the screen is shared already. Can you see the presentation?
The screen is shared. Thank you. And before Hala begins, I would like to remind you all that we have 25 to 30 minutes for Q&A, and Katie's controlling the chat box, so you could send your questions through the chat box and we will read them out following everybody's presentation. Thank you.
Okay, our project we titled My Life is My Choice. You can see during the presentation why we call it like that, and why even the adolescent choose to link between the life and the choice. First, I would like to let you know some information about Syria, if you don't know about it. Syria, it's a country in Western Asia. Is an entire state, but for several reasons. One of them is the administrative purpose, divided into 14 governorates, as you can see. I'm not sure if you can see it. Yes, now it's on the screen. 14 governorates, and those 14 governorates, sometimes they call it provinces, and in Arabic it's muhafazat. It's bordering with, if you don't know Syria, it's bordering with some famous countries. You hear maybe some of them in the news, or if, you read about them on papers, like Lebanon, Turkey, Iraq, Jordan, and Palestine as well. Based on the UN data, the population is around 18 million, but the estimate population number based on the statistical bureau, the Syrian Statistical Bureau is 22 million. But what we are sure about is that during the last years, Syria suffered from conflict, war, crisis, and it's still until now in 2 locations in Northeast and Northwest. So for that reason, during the last 10 years, lots of people displaced, lots of people left the country. They became refugees in the neighboring countries in Europe. And I think you hear lots about the Syrian who reached Europe, reached different countries as a refugees. And that's reached around 7 million out of the total population, and that of course affecting the whole situation economically, socially, and even in the political side. As of today, we're still suffering, as I mentioned, in 2 locations, the other suffering from the impact of this war and conflict during the last 10 years. Our project came to the surface in 2017 as part of UNFPA support under the Humanitarian Response Plan. At that time, and thanks for ECHO, they support us to provide into 2 locations a comprehensive support to provide all the mandate of UNFPA, including health protection and livelihood in Northeast, in the governorate, we call it Hasake, and in the western area, which is Hama. And this is the place of our location. In the next slide, you can see that Hama governorate, it's a small governorate. Yes, this is the one in the red. And Hama suffered a lot during the last 10 years because it's very close to 2 governorates with a high burden of the conflict, and some of them they still. So they have around 100,000 population, but they received similar number of population from north and from southern governorates, and that it's a big number as IDPs in one location where all the infrastructure affected because of the conflict and the crisis. And as you can see in the yellow one, this is the area of where we implemented our project to support adolescent and younger, in addition, of course, to other support we provided in these locations. Why we did that and how we select this area? Because we saw that lots of adolescents, they cannot access the services, not only the host community, but the IDPs coming to this area. This area has lots of affinity, so also that's playing a role between how people accepting themselves, how they can accept the IDPs, how IDPs can receive the services, and how can young people reach not only the health services, also education and different other issues. So the main objective was, as you can see in the next slide, is to ensure that the majority, or at least adolescent we can reach, they can receive services, they can reach health services, education. So we targeted them with multi-sectoral intervention. We provided health services, protection, and livelihood. And you can see now how we already provided. So please, next slide. And yes. So as I said, this is the main objective. The next. So how we provided. We saw that lots of IDPs, they cannot access because of these barriers between them and the host community. So we established a clinic to provide the health services, including sexual reproductive health. And it's a static clinic inside Masyaf city. And we have mobile teams to reach people in rural location and in shelters, of course, because at that time there were collective shelters. Now there's no shelters. People integrated and became part of the host communities, and they receive similar services for everybody. So here we link the services provided through the mobile team And we try to refer the cases they cannot access the services with support from mobile team. At the same time, because there is other activities cannot provided in the static clinic, like education, like innovation, like vocational training, we establish a small safe space center only for young girls because of the gender sensitivity in that location, because girls, they cannot access services without having a member from the family to combine them to receive the health services and to get other activities as well. So here, when we provided these two centers, with supported, of course, from ECHO and later from other donors, we could reach beneficiaries and young girls. They received the health services, and at the same time, young girls, they could have learning session, and that's supporting them to back to school later. Awareness sessions, so that means we could at that time to increase the level and the knowledge about sexual reproductive health and GPV as well. We provided psychosocial support because it was a very hard time for all women and adolescent girls in this area, especially for displaced young girls. And the last, we provided vocational training, and here we assessed the need and we provided what the beneficiary prefer. So we started with haircut, cosmetic, cooking courses, information technology, nursing, first aid skills, and sewing. Now we expanded, and I will speak later how we expanded, what kind of changes we made based on the achievement. We did it during 2017, 2018. So here you can see that the results in the next slide, reflecting that when we ask the beneficiary, the majority, or we received 100% actually satisfaction report about the service provided. Some of you, they might say, this is a satisfaction, so it's an individual opinion. Actually, yes, but when young people, displaced people, and host community, and that triangle agree together that this is services is important and they need to continue, and they ask us to continue to support in this location with similar activity, that means yes is important, and we have a positive results. And this successful experience actually changing and improving the life of adolescents. If you will ask me how, I will let you know that the majority back to school, lots of them now, they are at the upper level, which means they joining a very good undergraduate faculties. Some of them, they start to work. We supporting them with startup projects, so they have their own work, and some of them, they have families. So we thought that really what we already provided there is playing a good role for peace building and social cohesion as well, especially with this diversity of ethnicity in this location. What we learned from that, actually lots of lessons learned, but I will try to summarize in the next slide some of what we saw. And you can imagine that under each line, there is lots of lessons learned to, because of that, we came up with these big and general lessons. Like we prioritize intervention for the greatest impact. Because when we provided that, we assess how the impact was, and we continue that, yes, always we should prioritize the intervention based on the community needs, based on the adolescent girl, and all these issues. Comprehensive program, because we provided health, GPV, and as well vocational training and livelihood, so that it's very good for the intervention. From the other hand, we learned from previous experience in other locations how we can expand in this area and how involving and addressing the needs of the community. It's a must to be accepted, and also combining the intervention and focus on sustainability and community participation, like we saw that involving men in all the activities, at least during the awareness session, give us opportunity to reach more women and girls, and this is important to be and the key for successful. What is the way forward, and how we already after 2018, after we assessed after 1 year of implementation, actually we expanded a lot. And we copy that experience in many other locations, and we try to ensure the appropriate youth participation in this program, and always we are involving parents, teachers, and community leaders, because there is beyond what we are providing in the sexual and reproductive health ideas and opportunity to reach more adolescents and address really the needs they want. Always we depending on multi-sectoral partnership, use comprehensive approach, and look to the diversity and put it as into account when we are planning and designing any project or program. And of course, we are focused on prevention and health promotion. And actually, we added lots of other activities and lots of new approach and new modality to provide these services because of the situation. Like we added the telecommunication part. We are trying to use volunteers as a key to reach adolescent girl in all locations, not only in this area, because we still have other areas suffering from the conflict during the last year and up till now. You can see now some pictures, some photos, and hope I could send and more, but because we saw that young girl face an uncertain future and we are afraid that they cannot go out of that, but really what we provided in this location and copied in other location, you can count it at the first step in the 1,000 mile, the road of 1,000 miles that we should move on it. So you can see how they are happy. We started with shelters and with mobile teams, but later we have a real center, safe space for young girls in the next pictures. They are receiving lots of activities based on their needs. We expanded even the center and the location to reach as much as we can a vulnerable and young girl in this area and in other locations as well. So thank you very much, and I hope you enjoyed our presentation. And thank you, UNFPA, of course.
Thank you, Hala and UNFPA. One key thing you said was that youth need to be involved, and I strongly agree with that point. We will move on to Eden from IRC.
Okay. Thank you, Khadija. Our presentation title is Improving the Utilization of Modern Contraceptives Among the Adolescent Groups of the Refugee Community in Ethiopia. And this is the IRC experience that we would like to share. Next slide, please. So as part of the presentation, this is the outline of our presentation, and we would like to concentrate more on the results and lessons learned and implications for the future. Next, yes. So as a country, Ethiopia is one of the countries where there is highest fertility rates among the African countries. Here, sorry. So in Africa, so Ethiopia has some of the highest fertility rates in Africa, with those under 15 years of old age comprising of 45% of the population. So because of this, it became a commitment maker to family planning by 2020, so that we can decrease the unintended pregnancies and maternal days, reduce the maternal days and mortality rates as well, morbidity rates as well. So when we look at the teenage fertility in Ethiopia, it was about 12% according to the HIS 2011, and it became 13% in 2016. Again, when you look at the fertility rate per woman, it was 4.8 in 2011, and which is high, and 4.6 in 2016. As part of the WISH program, the WISH project is the UK government's flagship program to scale up its support to integrated sexual and reproductive health rights. So as part of the program, we have 4 cross-cutting outputs. One is individual choice, second one is national ownership, and third one is access to services, and the fourth one, global goods. So to focus more on where the WISH activities, the WISH program is implemented, we are focusing more on the humanitarian setup, where in the refugee campus of Ethiopia. So as IRC has been supporting the refugee campus located in Ethiopia like over 2 decades, and supporting in wash and nutrition and in health aspects. For the WISH program, we are focusing on 3 regions, 3 region located refugee campus. For those of you who may not know, Ethiopia has like 9 regions, and 9 regions which recently became 10 regions, and 2 administrative cities, Addis Ababa and Redwa. So these 3 regions are Tigray region, Somali region, and Benshangul Gumuz region. So in these regions, there are 12 refugee campuses. So in this refugee campus, we have a total of about 174,165 refugee population. This contains about half of them women, and about 44%, or in number 38,287 of them are women in reproductive age group. So IRC supports this ASRH project through its own community-based RH clinic and supporting the government facilities. In this case, it is called ARA Health Centers, which is Administration for Refugee and Returnee Affairs. So this project started in December 2018. So from December 2018 to March 2019, it is the inception phase of the WISH project. So during this inception phase, we have had conducted project launching meetings with different stakeholders, government stakeholders and partners. We've had meetings for signing MOUs and agreements. Again, we did also collect service data as pre-implementation service data during this period. Again, after that, after starting some of our implementation activities in March 2019, we have done major activities for the implementation phase. I will summarize those activities in 3 groups. One is awareness raising and activity planning activities, that is community sensitization basically. Again, the second one is capacity building the capacity of both the facilities and the providers through trainings and stocking of facilities. And the third one is integrating the SRH services with other healthcare services provided in the facilities. So for the result part, I will hand over to Argav for the presentation. Argav, please continue.
Thank you. The next slide. Thank you. So I'm going to just mention some of what are the results after the a number of interventions have carried out. So IRC has reached around 101,600 users with different family planning uses. So from December 2018 to February 2019, it was inception phase, as Eden has mentioned. From March 2019 onwards, there is high interventions are carried out, so the number of family planning users are increased. As you are seeing, in June 2019, the number of family planning users are around 8,440. So the trend is showing as of June to June 19, there is a continuity of family planning users. Even in April 20, if there is a COVID issue as of January 2020, even during the COVID period, even the family planning users are still continuing. Even there is some slowing down around April, but due to the program adaptation, so the family planning users are still increasing. So next slide. So when we see the adolescent family planning user from age 15 to 19, as mentioned in the previous slide, from December to December 18 to February 19, we didn't get the use available data. So because as we are getting the data from the government HIS, so we are not able to get the data on that. So as of March 19 to May 2019, there is as a number of interventions has been, so the number of used data are getting a little bit increased. But in between, from June 19 to August 19, there is in between, we were not able to get the data in this area because at that time, the ARA, the government agent who's working in the refugee area, has changed the health information system or the capturing system. The health information system for ARA was only split into two, less than 80 years and greater than 80 years. So we are not able to get from 15 to 19. So RRC has devised different strategies. So they assigned the health officer to go to collect from the primary registration book. So in that way, we are able to collect the data on the users, on the adolescents. Please in the next slide. When we compare the percentage of the FP users by the age, as you are seeing the bar graph, the highest percentage of the FP users are adolescent. I mean, the age, those whose age are greater than 25 and plus, and the next is from 20 to 24. So the users are the percentage of FP users for use are a little bit low, but this implies IRC to strongly follow up and increase the FP uptakes. The next slide. So when we see the contraceptive method mix, we took two quarter report, February to April 2019 and the 2020. When we see the two pie charts, there is an increase, there is a shift from short acting to long acting. If you see, the injectable was increased from 33% to 46%. And if you see from April 2019, the implant was 7%, but in 2020, it is 70%. And when we see the condom usage in 2019, it is around 27%, but there is a decline in April in between in 2020. So there is a shift from short acting to long acting or lag. So this is due to the close monitoring, the follow-up, and the mentoring, the different capacity building that the RSC has undertaken. Next slide. So the RSC also conducted the RSC also conducted the annual claim exit interview in collaboration with the external consultant. So we contact around 86 respondents. Of these 86 respondents, around 36% of them are from 25 to 29 years old, and only 4% of them are 15 to 90 users. So of these, around 39 of them are housewives. Of these 35%, half of them, more than 53% of them have more than 3 children. We also asked the satisfaction, the claim satisfaction with which family planning services. As you are seeing the black and the blue color, most of them are satisfied with the service that the RSC is providing with regard to the FP service, but only minor dissatisfaction is about the clinic operating hours and the waiting time. So this is some of the dissatisfaction that they are showing. The next slide. And next slide, please. So we also asked during the client exit interview whether they are referring or recommending the other users. So more than 73% of them they said that they will recommend the FP services to the others. So the next slide will be presented by Eden, and over to Eden.
Yes, sorry. So to just share some of our successes and challenges that we have faced. So our success is to see that increased adolescent use access to contraceptive, and to see that the method shift, especially from short-acting to long-acting family planning services. And we have had we have good collaboration with the Ministry of Health, with the local government and partners. Again, using peer volunteers also to penetrate, those adolescent groups was also one of the successes that we have seen. Again, we have gone through also program adaptation, and that has we have started to see the success of going through the program adaptation, especially during this time of the COVID pandemic. So our major challenges that we have faced were data harmonization, which was reflected also on the result presentations over the Q1 and Q3. Insecurity and outbreaks were some of the common challenges that we have faced as a country. High turnover and understaffing of public facilities was also a major challenge that we have faced. Again, due to the agreement process with the government, it took a lot of time during the inception phase as well. That was our biggest challenge during the beginning of the project. The other is engagement of users were not taught carefully before the start of the project, and that was the challenge that we have faced. Next slide, please. So far, the lessons learned from this project is, as I mentioned earlier, standing from the challenges that we have faced, we need to have a user-centered, especially adolescent-centered design approach as part of the program. In program adaptation is critical in humanitarian setting, especially because of the dynamic nature of the refugee context, because we have here three types of refugee camps located in 3 regions. Like, for example, the Asosa refugees are coming from South Sudan. Those refugees located in Tigray region are coming from Eritrea. Again, those located in Jijiga or in Somali region are coming from the Somali refugees. So the context is very different, and program adaptation is critical in humanitarian setting. The other is lessons learned is important to engage with youth. Again, stakeholders engagement, especially local government engagement here in Ethiopia, is very important. Next slide, please. Implications for the future. What we recommend is that, as I mentioned, refugee settings are very complex and dynamic. They change every time. Like if there is a huge influx of refugees coming from because of conflict or war, the need increases. Again, with the different policies at the refugee setup, different interventions need to change. Project interventions and documentation of progress made, building on evidence practice. Again, the other implications in the future is the program will provide some guidance in approach of enhancing joint collaboration with the government, especially the Ministry of Health and the ARA. This is to improve the service delivery and to inform the local government to take commitment. Next slide, please. So finally, I would like to share the COVID adaptation in humanitarian settings. So far, looking at the humanitarian setting or the refugee setup, it makes the COVID transmission risk very high. This is because of the poorly developed health system capacity for COVID, and the low technological reach in some of the areas in the refugee campus, because they are remotely located and infrastructure is not that much delivered. It's not that much accommodating the infrastructure itself. Again, additional civil disturbances, especially that is what we have seen in the refugee campus of Asosa. Impact on our program, on the WISH work, is that it made it difficult for the community mobilization and sensitization work to go ahead, because most of our sensitization and community mobilization work depended on person-to-person community sensitization. Global shortage of infection prevention equipment, the PPE supplies, again, some of the contraceptive supplies were in shortage. Declining facility attendance for ASRH services despite availability due to fear of COVID increases and rumors. So again, the shift of attention from the other ASRH programs to COVID also affected our work. So as an adaptation, what we did was we tried to adapt we did adopted actually the service delivery, again, the community sensitization work. So as part of the service delivery adaptation, program critically assessed and planned for implementation and appropriate mitigations. Again, preposition of PPE supplies or program emergency medical supplies, self-care strategies. Again, trained providers and the social health workers as well on prevention of COVID, and focused on NISP and the mental health psychosocial support. So as part of the community awareness work also, we try to focus more on innovative measures like mass media, and using mobile phones for frequently asked questions. Again, we also expanded our coverage on IEC and the CPCC materials. This is integrating the ASRH message with the COVID preventions. So these are how we adapted with the COVID situations. If you have questions, you're welcome. Thank you.
Okay, hello everyone. I see my slides, so I'll go ahead. Khadija, do I wait for you to say something?
I'm sorry, I was trying to get unmuted.
Go ahead.
Okay, so we welcome Sarah from Save the Children. She's the Director of Maternal, Newborn, and Reproductive Health in Emergencies. Thank you, Sarah.
Thanks, Khadija. So I'm going to speak about our project example from Yemen. I will focus more on, it's a larger program, but I'll focus more on what we were able to do for ASRH. Next slide, please. So I'll speak about the Yemen context and the humanitarian situation, a little bit about our program, and then dive deeper into the adolescent programming in one area, and then our way forward. Next slide, please. So in terms of Yemen as a humanitarian situation, the conflict has been ongoing since 2015, March of 2015 to be exact. And the situation has been getting worse since then. The overall population is about 28 million people, but 80% of them need humanitarian assistance. 50% of the health system is non-functional, according to WHO's HIRAM's report. And the 50% that is functional is only partially functional, which means that when we visit health facilities, not all aspects of the health facility or service delivery are available. The new challenges that have been happening since the beginning of 2020 are, of course, the COVID-19 pandemic has also affected Yemen quite strongly, and there is a lot of evidence of community transmission and spread of COVID-19. There's a rise in conflict again, and then there is a significant cut in the humanitarian funds that are coming into Yemen. So only 18% of what the humanitarian needs were have been funded so far for 2020. The famine threat has re-emerged due to the economic crisis, and there are many other disease outbreaks that are happening alongside the COVID-19 pandemic. To name a few, there is dengue, there is malaria, and there are those that re-emerge usually. And now with the recent flooding that is happening, both it started in the south and now in the north as well, there is a fear of resurgence of cholera as well. Next slide, please. Next slide. So Save the Children has a relatively large program in Yemen. All the red highlighted areas are the governorates where we have programming. Programming is integrated, so it's health, nutrition, protection, livelihood, education, and others as well, WASH particularly as well. We support about we support about 300 plus health facilities through different grants, and there are different levels of services that are supported by Save the Children. The project that I will speak about is being implemented as a family planning post-abortion care project. It is in Lahaj. You see Lahaj at the very bottom of the map, the kind of the last governorate at the bottom, and then it's also in Hodeidah, which is the governorate you see on the very side, the coastal area. But the ASRH programming we were really able to do only in Lahaj, and I'll explain in a bit, please. So the larger family planning post-abortion care program, we support 6 health facilities in Lahaj, 10 in Hodeidah. It's about a target population of above 200,000. This project has been ongoing since 2013, so it has been quite a bit of time where we have had interventions for both family planning and post-abortion care. It's important to understand this aspect because as we went ahead and spoke to our adolescents, some of the answers that we received, I think, were very much affected by how long this program had been running and how well maybe these health facilities are known to the communities. I am emphasizing on this because I would like to say that if we were to go maybe to some other catchment populations out of this project area, we might see a very different picture and not so much affiliation with the health facilities might be seen. So within this project, we have done a lot of community engagement. We have done a supply of commodities, training, a lot of focus on supportive supervision and direct support to service providers at these health facilities to improve quality of services, a lot of one-to-one coaching as well. So a lot of time and effort has gone into this project overall. For ASRH specifically, some years back, we started collecting age disaggregated data. So we were able to see how many of the new users for family planning and for post-abortion care that come in are between the age of 15 and 18. We were also then able to do some other activities which are listed here, looking at our health facility readiness on ASRH, training of the service providers on ASRH specific services, and then providing direct supportive supervision with a lens on ASRH, and then engagement of the adolescents, speaking to them about reproductive health services and about what they thought was important to them. And I'll share some of the results from this engagement that we did with the adolescents. So we spoke to the adolescents mainly in Lahaj. We were not able to do this in Hodeidah. The reason being, for those of you who are aware of the situation in Yemen, the country is kind of divided into north and south. So the government in the south is relatively easier to work with in terms of sensitive issues such as reproductive health. In the north, it is very difficult to get approvals for work with adolescents or even diving deeper into some reproductive health issues. So we were not able to do this in our 10 health facility catchment populations in Hodeidah. What we did, we had focus group discussions with adolescents. We divided them by being married and not married, and by being female and male. We selected 4 different districts. 2 of those districts were relatively urban and 2 rural, so we kind of see some differences along these lines when we looked at what we had. The focus group discussions were done in Arabic. They were pre-arranged. with groups. We had to get lots of approvals from different levels in order to do those. And that's why many of the adolescents that we spoke with were very close to those, in those catchment populations around those 6 health facilities. So this is why many of the results are also maybe more positive towards the health facilities, which might not be the case if we went to other health facilities outside these catchment population. Next slide, please. So our topic areas were around those that are listed here. So we had questions around puberty, around health and RH-seeking behavior, roles and responsibilities, differences between males and females of the household, age at marriage, and then reproductive health services. So childbirth, STI treatment, family planning, and post-abortion care are the ones we focused on. I'll share in summary because I know that our time is short, but we will definitely be sharing something once we have it all written out, which would give more depth into some of these results. So for puberty, most of the adolescents were able to mention signs of puberty, but it was interesting to note that the girls mentioned the signs of puberty for females, but not for the males. And the males mentioned for the males, but not for the females. So they were not either comfortable mentioning the puberty signs or they didn't know. So this is something we are not very well aware of. Where they got their information when they spoke about these signs of puberty or anything related to reproductive health, it was interesting to note that the married females were, relatively speaking, about they would get information from their mother, from their close relatives, from their husband, sometimes friends. But as we move to the non-married females and also male, there was more mention of social media, of the internet, more mention of friends rather than close relatives and mother. The health-seeking behavior was kind of interesting to note that all of them were aware of the health facilities, and that's why I kept mentioning that the long-standing project might have influenced a lot of how well they knew these health facilities. They were aware of the health facilities, they were aware of the service providers, they were mentioning how there was a positive reaction from the service providers. They were able to go, they were able to ask their questions. However, there are some differences, disparities. The married girls went with, or actually all of them went with someone. They were accompanied by someone. So none of the respondents really said that they went alone to receive services from the service providers. The married girls went with their mother or with someone close to them, sometimes with their husbands. And those who were not married mentioned that they also went with their mother, but they did not mention that they went for family planning services. So when we come to family planning, we'll see a bigger difference. There was mention within the groups that we spoke with from the rural districts. They mentioned that the service providers were very overwhelmed, that they had a lot to do, they had a lot of different clients and patients, so they felt like they didn't have enough time for them to ask their questions. Again, in terms of health-seeking behavior, there was a mention of how in the rural area particularly, how they would wait for an illness to be on the severe side before they would go for services. So mostly they would try to manage things at home. Health-seeking behavior was also associated with the ability to pay for transportation in order to reach the health facilities. So that was also one barrier that was mentioned. They did not have enough finances to pay for transportation, so they would wait more for a severe level of infection. In terms of roles and responsibilities, the answers were very similar, whereby the role of a female was to be home and to be the caretaker for the house and for the children, and the role of the male was to go out and to be the breadwinner. It was interesting to see how there was mention from the not married group that some of these roles and responsibilities had changed. The married groups did not mention the change in roles and responsibilities, but the non-married group mentioned that because of the issues and what Yemen was facing, it was now more possible for females to leave the house and to do other activities outside the house to be able to earn money and to be able to support. Age at marriage was relatively mentioned by all of them very low. So everybody gave the figure 15. So girls as young as 15 years are married in Yemen. They all mentioned that this age had gone lower since the onset of the conflict. And this kind of corresponds well with some of the research that UNFPA has also done in Yemen, which says that they estimate that 60% of girls below 18 years of age are already married now in Yemen. There was a clear reaction to this early age from all of the groups that this was not something good, and they were able to mention the side effects that it had for young girls who married this early. So a lot of the issues that were mentioned were their lack of ability to carry a pregnancy, to go into childbirth. There was mention of prolonged labor, complications. Specifically also, they correlated some of these issues with traditions, where they said the traditional way for Yemeni women generally was to give birth at home, but for these young girls, that was even more difficult. There was also mention of how this early age marriage, for boys, it was a little bit higher. I forgot to mention that. So for boys, they were mentioning the age of 24, not as young as for the girls. But in both cases, there was mention that because of early marriage, both boys and girls had to leave their education and focus on either supporting the girls, supporting within the household, and the boys having to go out and earn a living because now they were married and responsible family. In terms of childbirth, for STI treatment, it was pretty amazing to see that they were all able to go to the health facility accompanied by their mother or someone. For family planning, they were also able to go if they were married. So that was a very clear response. The non-married groups were not able to go for family planning for contraception. Post-abortion care was the same. Only the married adolescents were able to go if the girl was married and had bleeding, severe bleeding, could go to the health facility, not the unmarried ones. In terms of family planning, something I would like to mention here, our data is showing us that there hasn't been a decline in new users, both among adolescents and even older women with the COVID pandemic. So we actually compared our data January to May 2019 with January to May 2020, and we have seen an increase in new users for family planning, increase in post-abortion care, increase in acceptance of family planning after a post-abortion care service. And that steady increase has also been seen among adolescents, and of course the married adolescents, because it was clear from this consultation that the not married adolescents were not getting services on family planning post-abortion care. Next slide, please. So a little bit on our way forward. We definitely will continue to work within this project to collect more data and understand better how we can support these health facilities to do much more. I think it'll also be interesting for us to really see other health facilities that did not have such strong interventions for this many years, to really see how well the adolescents are informed in those catchment populations and whether they're even able to go to those health facilities. I think that comparison would be really critical to do, and we are able to do it because we have other grants, support to other health facilities. I think a lot of work has to be done with service providers still to try to see where are the barriers for the not married adolescents to access services. There was mention by some of the adolescents on how it would be better to have services integrated. So they spoke about sexual violence a lot, which is also interesting, and maybe that is also an aspect that we need to speak to service providers about. Looking at engaging the adolescent groups maybe in a different way within the communities, not just for providing information, but really from understanding from them what are some of their other issues, not directly related to health and reproductive health, but related to other sectors and subsectors. I think my time is up, so I will stop here, but I'm happy to answer questions.
Thank you very much, Sarah, and to all of our panelists. We now move on to our Q&A segment. And the first question for Hala is, vocational training is not in UNFPA's mandate. How did they manage this? We're waiting for Katie to unmute.
Okay, thank you very much, and thank you for all colleagues for the nice presentations. And it's for Yemen, it's look like some of the points it's similar to what we are facing in Syria. Vocational training, yes, it's not a UNFPA mandate, but because we were in a humanitarian response, and you cannot split what are the needs in the ground and say only we are providing sexual reproductive health. Actually, we follow are the needs in these districts or these locations. And because we are providing support through Women Girl Safe Space in other locations and even in the same governorates. And this girl center, it's similar activities like what we are providing safe space, like psychosocial support, and even referral to health services and case management. Part of the support was to provide the vocational training, because this is need for those people. Track them to attend and receive all what we need to provide. And we can reach more people through having a group of women and younger who are receiving. And later they can somehow distribute the information, supporting the community, each one based on their location. And we get the approval from authors, our regional office, and at the same time, because we were in the fast track procedure, May supported us. And because the UNFPA is the lead for GPV subsector, us a lot, because they count vocational training and integration with and complementarity with other UN agencies' livelihood activities is something important to sub-communities and vulnerable population. But of course, we don't continue with the involving women in the labor market or something like that, because this is the mandate of other UN agencies. But we have and we started that even before this project, a very good UN agreement and complementarity with UNDP, UNHCR to support those women after receiving kind of activities in this center or in any other centers. Thank you. Khadija, do you want us to go through other questions?
Sorry, this is Katie. I think that Khadija is having some trouble connecting, so I'm just going to, one of the IRC colleagues jumped in to provide some answers to the questions. I'm just going to read her response from earlier in the chat, and then Arga and Aiden, you can let us know if you have any more information to provide. So some of the questions were, with the reduction in utilization of the male condom, are we not concerned about STIs or HIV? Perhaps dual methods would have been desirable. Was there a focus on LARCs compared to short-acting methods? Is this why we see a shift from short-acting to long-acting? And what can we say about the availability of different methods? And then finally, what type of family planning services are offered for these adolescents? And Caroline already discussed that on the method mix, the project is able to document only those issued in the service delivery room. When we address some of the misconceptions that providers had on family planning in youth and the provider skills gaps, we saw providers beginning to counsel adolescents on more effective contraceptive methods, including LARC, and providing the same. However, condoms are largely distributed in strategically placed dispensers and during various interactions with youth, even during community sensitization, and are not popularly picked from providers. Change is a positive step, but the IRC team is working to improve reach and understand what works best, learning from its interventions. So I'm going to hand it over to Aiden and Arga. Do you have anything else to add?
You want to go?
Yeah. Just I want to respond for the questions that Dr. Else has raised on some of the points on the declining of the adolescents from age 15 to 29. There is a question that why there is a decline from, there is an increase from August to October or December, and there is also the reverse decline. And so in this regard, between June 2019 to August 20, as I mentioned, there was a shift of government in changing their HMIS. So the age was only separated into 2 age groups greater than 80. So we were not able to get this information during that quarter. So in the next quarter, IRT has managed, devised a different strategy, and that was to assign the health officers and directly collect from the primary data source, which is from the register. What is we are collecting directly from the registration books, but there was a decline from November, around December to March 20. This is because of the security condition, especially in one of our camps around Benishangul area. For at least 1 quarter, there was no internet, and the communication was disrupted, and even not only communication, there was no movement, and we were not able to undertake any act. One of the difficulties that we encountered, we were not able to undertake intervention, and we are not going to get that, especially in the one of our camps where in the Benishangul Gumuz. The other question, which was asked by Bibiche, how did you manage the visit at the health facilities? Yes, in different health facilities, there is a separate family planning unit, the counseling room, not only for the family planning, but also for the PAC and the CAC service. There is a separate counseling and separate service for the different MSH. We have different MSH units. So there is privacy and the confidentiality is kept well. So that is there is not much an issue in most of the health facilities in Ethiopia. Even in the around the community-based health delivery unit, we have that is dedicated for the planning uses. So that unit, community-based delivery units are dedicated for the family planning users. So it's a very separate room. There is separate counseling and a separate service units. So this is what I add. So Eden can add some on what is.
Thank you, Argo. Sarah, can you clarify what services were provided for the post-care, and we should provide PAC services?
Yeah, I think I'm on mute now. So for post-abortion care, we provide the whole range of service. So there's pre-service counseling, and then MVA, misoprostol, and then there is counseling for the client to accept a family planning method before discharge from the health facility. Done for anyone who arrive where they have bleeding or issues, and the way the service providers have been trained, have been training. There's also a lot of other training that goes in terms of attitude and in terms of not asking questions and keeping confidentiality, even if they are able to tell if that abortion was induced or not. Suppose managing the complications of abortion through those service provision. What we have seen in the past years is that the service uptake is increasing. We have also seen that there is an increased acceptance of family planning before discharge from the health facility. So currently our data shows for Yemen that almost 40% of those who receive treatment for post-abortion care treatment actually do accept a method before discharge. And the family methods that are available for all, including for adolescents, so implants and IUDs, short-acting methods, pills of both kinds, and there are condoms also available if someone was to ask for them.
Thank you. Can you?
I just saw the question on abortion. Abortion services are not provided in the health facility support. I am aware that they are provided within the health system, but not the health facilities that we support. From my understanding, that abortion services are available for certain specific cases, and they are authorized by the Ministry of Health, but they're only a level secondary, but it is not something that is spoken about in Yemen. It's not something that is openly mentioned. It's also something that is easy to speak about. I have to just, probably I didn't give a background, but Yemen is a highly sensitive country, and maybe Syria, Hala, if I may, it is very, very difficult to openly discuss a lot of these RH issues. I think we have made huge grounds on bringing some of these issues out in the open and speaking about them. Just speaking about post-abortion care back in 2013 and before that was impossible. But today we speak about it. It's part of their guidelines. It's being talked about within the ministry. Services are being provided. So I think we're highly sensitive, both in terms of what the ministry agrees on, but also what the community traditionally, socially agree on as well. But we're moving in the right direction. What's happened over the last years? So, yeah.
Thank you, Sarah. Another question: if unmarried adolescents are not allowed to get PAC and FB services at health facilities, where do you think they're going to get these services? Is there any advocacy going on in Yemen to make adolescents access all services?
So the way the response spoke was more on their own cultural and social norms rather than a reflection of the service providers. I think there are two things here. If you remember, I said that they kept with their mother or a close relative to the health facility for any illness that they felt. So maybe assumption can be made that is one barrier. Socially, culturally, if an adolescent is going with her mother, she may not ask for contraception. The other side of it, in terms of service providers and health facilities, we are doing a lot of work within this project in sensitizing service providers and trying to ensure that they provide services to anyone who comes without going into too many questions of married, not married, IDP, no IDP. So we kind of go across a very broad spectrum of issues that we feel there could be stigma against. However, saying that, I think it's important to note that only facilities that we're speaking about, I kept mentioning that there's a lot that is outside this program. We need sort of the learning that we have from this program. Culturally, I think it'll take a lot to openly speak and say non-married adolescents should be allowed to imposed upon those services. But I think we have a lot of windows through which we can approach this. I think the biggest window we have is married adolescents. If we're able to at least provide services to the very, very young, this is a big step forward. The other window is through ensuring that SGBV services are available. That is where we need to also strengthen ourselves, because if SGBV services of good quality can be made available, it is very possible that adolescents will be able to come on their own to ask for other services.
Very much. And that's all the time we have joining us today, everybody. We'll be sharing the pre and the recording, and we will also follow up just to share answers to your questions for those we missed. Thanks for joining us today, and I wish you a pleasant hour in the world.
Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you to all. Thank you, Khadija. Thank you, Katie. Thank you, everybody. Bye-bye.
Thank you.
Bye.